Thank you for joining my presentation on attitudes and practices of physician-assisted suicide in the United States. My name is Terrence Shenfield, and I've been an education coordinator for the last 30 years. I wanted to mention that this particular topic satisfies your medical ethics review for your licensure renewal. When you think about physician-assisted suicide, this happens when a physician facilitates the patient's death by providing the necessary means or information to enable the patient to perform the life-ending act. The physician can order some sleeping pills and other medications that will be a lethal dose, and in actuality, the patient actually takes the medication. It's understandable that many patients suffer at the end of life. Some of them have terminal illness with pain that's beyond control, and they really want to take their own life at this point. But there are many ethical questions in regard to this. Many people believe it's okay. Some of us believe it's not. I am sure each and every one of us have seen death, have seen suffering, and each of us have our own belief on this. So I hope you enjoy this presentation, which we'll get into more details as we go along. The objectives of today's presentation is, number one, I'm going to describe what is physician-assisted suicide, and more importantly, how does it differ from euthanasia? I'm going to give you some statistics on states that have used it. I'm also going to talk about religious concerns. Many religions, such as Christianity, Judaism, if you are a Muslim, if you have any other kind of faith, Hinduism, all of these beliefs believe that you should not take your own life. I happen to be a Roman Catholic, and I would have concern about taking my own life because I feel suicide would, damn me to hell. But I don't know what it's like to be in pain, to be elderly, to be, diagnosed with a deadly disease that they give me 6 months to live. I don't know what my practice will be. I'm going to talk about states that allow this practice. Not every state across the country allows physician-assisted suicide. And the truth is, we learned from the past. In other words, states that actually started doing physician-assisted suicide versus newer states that just passed the laws actually have learned from the past laws. Then we're going to talk about the DWDA, which stands for Death with Dignity Acts. These are very important acts that are laws in certain states that allow patients to actually take their own life. So I hope you enjoy this presentation. This slide speaks volumes. Here you have a woman on the left who's elderly, who says, "I'm old, I'm disabled, I support choice." What she's saying is that if she wanted to take her own life and she was terminally ill and been diagnosed by a doctor, actually 2 doctors, that her case is terminal and that she has less than 6 months to live, in certain states she could actually take her own life. And I'll get a little bit more details with that. There you got a young woman on the right, and she says legally endorsed suicide, easy to do, a hazard to your family. Who's right? Whose opinion is right? I don't know. I mean, I could say one thing. As healthcare practitioners, we have all witnessed death. We all have seen families, just broken apart about decisions. Who wants to be kept on a ventilator? Who wants to be removed from the ventilator? Who has power of attorney? All of these things have created havoc within a family. To be able to take physician-assisted suicide and actually commit suicide and actually do what you need to do to kill yourself, it's a law, and there are certain standards that are going to be followed, and you really got to be cognitive. In other words, the person who's doing this got to be with it. You can't be depressed, you can't be mentally ill, you can't be under duress. You really need to make the right decision. So this is a hot topic, and I'm sure each of you feel a certain way. I can ask you, how many of you do you agree that you should be able to take your own life if you're terminally ill and you make your own decision? It's called autonomy. I don't know. So as time goes on, many states across this nation grant physician-assisted suicide. So I did a little review as of June 28, 2021, and the map doesn't match the list. I wish I had a better map, but these are the states that contribute or allow physician-assisted suicide: California, Colorado, Washington, D.C., Hawaii, Montana, New Mexico, Oregon, Vermont, Maine, New Jersey, and the state of Washington. All of those states have what is known as Death with Dignity Acts, and basically they have laws in place to allow a patient to make a choice with their own life based upon their medical condition. And I am sure as I present this presentation in the future, this list will grow. But as of today, June 28th, here's our list. I wanted to share with you some stats of states who used physician-assisted suicide. And if someone does physician-assisted suicide, it's mandatory that they report this to the state. So these are good statistics. I'm sorry to say that the statistics I have from 2017 have never been updated. I took a look at the website yesterday, which is 2020, and I seen that they used the same data. So just to give you a feel for this, Oregon, as of January 23, 2017, reported 1,127 deaths by physician-assisted suicide. In Washington, since 2009, there were 917 deaths. And then Vermont, as of 2017, they actually had 53 patients who actually did physician-assisted suicide. Now, I have a graph, and I'm sure the amount of people who have utilized it in other states like California, New Jersey, and so on, they have their own stats. But you could see that a large amount of patients actually do this process of ending their life. In medical ethics, there's a very important concept called autonomy. Autonomy is the God-given right for someone to make choices for themselves. They could choose what they want to eat. They could choose what they want to wear. They could choose who their partners are. This is autonomy. When it comes down into physician-assisted suicide, the people who make the choices to sign off on this and get assessed by a doctor are mentally stable. You cannot be under duress. You cannot be depressed. You cannot have any kind of bipolar incidents. You have to be cognitively aware of what the ramifications of your choices are. So when someone says autonomy, they're talking about their right to make a choice about what they want to do, about making decisions one way or another. Also, a lot of people who get physician-assisted suicide consider dignity. Dignity is another very important concept, that people feel that at the end of life, they want to die a dignified death. They feel like if they were intubated and they had IV lines and people around them, and doctors, nurses, and family members, they feel this is not dignified. So autonomy is a very important concept, and we must respect what patients feel, just the way I must respect what you feel and you must respect what I feel. So autonomy is a very important concept in medical ethics. The law that made physician-assisted suicide legal in Oregon is called the Death with Dignity Act. And this law that was passed in Oregon, since Oregon was the first state to actually do physician-assisted suicide. So in Oregon, if you were an Oregon resident and you were terminally ill and you were diagnosed by a doctor to have less than 6 months to live, the physician would order a medication for you that you would take, and you would take this medication and you would pass. So the physician would never inject you with a medication that would kill you. Actually, you self-administered the medication. This law does not consider this suicide. They actually consider this, it's a Death with Dignity Act. So some of the rules with that is that you got to be at least 18 years of age. You have to be a resident of Oregon. you have to be capable of making a decision. In other words, you cannot be in a semi-comatose condition. You cannot be signed off by your parents or your wife or your husband or your brother or your sister. And you really need to be diagnosed actually by two physicians. One doctor confirms that you have less than 6 months to live, and the other one will confirm that diagnosis. And as you can see with the graph on the right, it all started around 1998. So Oregon was the first state. And I wanted to make a little point here. You notice the graph on the right, you have a blue bar and you have a green bar. The blue bar represents patients who actually received a prescription from the doctor to do physician-assisted suicide. The green bar actually represents how many people did it. So in other words, there were many patients who received the okay and received the prescription with the lethal dose of medication, but chose not to do it. But as you can see throughout the years, the number of cases of people doing it gets higher and higher. And this graph is just speaking about Oregon. It's from 1998 to 2015. This is an example of how they do physician-assisted suicide in Oregon. And the death with dignity laws never allow a lethal injection. So there's never someone comes to your bedside and gives you a lethal injection and then you die. Basically, you get a prescription from a doctor. So basically, you actually see two doctors. One doctor will diagnose you and tell you have less than 6 months to live. The second doctor will verify that diagnosis, and so you need two doctors to sign off on it. Once that happens, the doctor will write you a prescription, which you'll go to your normal pharmacy, CVS, wherever you go, Walgreens, and you will pick up a prescription of either Seconal or Nebutol. When you think of Seconal or Nebutol, both of those are very powerful barbiturates, and the dosing they give you are lethal. So this is not just a normal dose of Seconal or a normal dose of Nebutol. What the problem is, when they first started, they would actually vomit. So some patients actually took some Seconal, a lethal dose of Seconal, and about an hour and a half later, 90 minutes later, they vomited and they didn't die, but they had some severe damage to themselves because, they were depleted from oxygen in the brain. So now, besides getting the Seconal or Nebutol, they give them a dose that will actually prevent them from vomiting. And they make it taste kind of sweet. They added like a juice or anything like that. Basically, the patient will just take the medication, maybe have some family members around, sit in their favorite chair or their favorite couch, and they pass. So that's how they really do it. Now, the next slide is going to be kind of interesting. I'm going to show you how they do it in some states, especially in California. In California, they came up with a new method to do physician-assisted suicide, and it's called the Saw Call Capsule. In that, the picture is on the right. Basically, you would step into this chamber, and it would slowly deplete the oxygen in the chamber. And you would not, you would think you would suffocate, but you really don't suffocate. You actually just fall asleep, and then you die. And they found that through studies that this method actually causes less distress than actually the pills, the Seconal Nebutol. So if you are a Star Trek fan, which I don't know if you are or not, or if you know anyone who's interested in going this way, they actually felt this was a more humane way of doing physician-assisted suicide. Quite interesting. So what is the role of your faith in committing physician-assisted suicide? I happen to be a Roman Catholic, and I always believed that if you committed suicide, you're going to hell. And I thought that was my own perspective, that, you cannot commit suicide. I asked some of my colleagues, I felt it was unfair just to say, what Catholics do. So I asked some other Christians like Protestants and Lutherans. I also asked some Hindi people, and I asked some Jewish people what their faith was, and also Muslim. And every faith does not believe in assisted suicide. No one believes that you should commit suicide. It goes against all the rules of anyone's religion. So in the Catholic faith, what exactly is their point? And what they come up with, I did some research on this, they say voluntary cooperation in suicide is contrary to moral law. And they felt that this was a selfish act. They didn't say you're going to go burn in hell, but they do feel that goes contrary to moral law, and they actually called it a selfish act, which, is hard to read. But most people I've talked to in my audience who have any various faith all don't agree with physician-assisted suicide. They believe that their faith tells them differently. Now, let's talk about a different perspective. We're all healthy. We would not consider it. But suppose we had 4 months to live. Suppose we're in pain. Suppose we're in such duress and we just feel so undignified. What do? Maybe you would change your opinion, because actually there's a lot of people now, a lot of people with faith who are actually doing this physician-assisted suicide. So it's a can of worms. You don't know exactly what everyone's feelings are about it. I wanted to get a couple of definitions out of the way. One of those is euthanasia. The other one is physician-assisted suicide, and the other one is palliative care. When you think of euthanasia, this is death caused by intentional lethal dose of medication ordered by the physician and administered by the physician. So when you think of euthanasia, this is that the physician will actually give you the lethal dose of medication. They won't order it for you. They'll give it to you. And there's two forms of it. There's what they call voluntary and involuntary. Voluntary is in some countries like Switzerland and Colombia, they believe that if a patient wants to end their life because of their medical condition or whatever, they can ask the physician, and the physician agrees, he can inject or she can inject this medication. Involuntary, in the same countries, if someone gets in a motor vehicle accident and is in sort of a vegetative state, they could just arbitrarily end your life because they feel like, clinically or medically you're not going to survive. With physician-assisted suicide, which you all know about, you need 2 doctors who agree that you have less than 6 months to live. You have to be cognitively with it, and you are self-administering. In other words, the patient takes it. They go get the prescription, and they take it. Now, when we think about palliative care, this is being used more and more throughout the hospitals. Throughout my hospital system, when I first started seeing palliative care being used, we were really not doing it very well. But over time, we learned, and a lot of people are doing some really good palliative care these days. Actually, it could reduce the number of physician-assisted suicides and actually causes a lot less stress to the patient and family. So palliative care is really, really important because it relieves all the pain, depression, shortness of breath. They really give you medications to sort of lessen the symptoms that make you feel horribly. So you may ask, why do people do physician-assisted suicide? And everyone has their own reason. Some of the most published reasons why, they did talks with patients who were going to do this, and they wanted to know why you were going to do it. And some people are just afraid of a tragic death. When you die and you're up in an ICU, or and sometimes you're in hospice, and so typically you're in pain, you're uncomfortable, you're under duress. So people just don't want to die like that. And, they figure if they got 6 months to live and they're in such pain now, they don't want to do this. Some people have witnessed terrible suffering. Some people have seen other people who have died and they realize how much pain they were in, and they don't want this. So that's another thing. Another thing about pain and suffering, people have witnessed death. I'm sure all of us who are listening to this PowerPoint have witnessed death and have witnessed suffering. And it's not a pretty picture, especially for the family members, for the patient, everyone. Some people feel when they get when they have a terminal illness, they lost control and they feel that they actually, can't make any judgments and there's no control in their life. So this could be a reason. Um, Another big reason is some people feel they're being a burden to the family. When you think about it, when you're at your end stage of life, you could probably deplete all your savings. Your lifelong savings could be all eaten up. Sometimes you might feel that you're a burden to your family and you don't want to see them suffer because you're suffering, they suffer, and some people feel they're a burden and they're a burden to their family and they just like feel they want to end this quick. They want to go this with dignity. And another thing, the key word is dignity. People want to die in a dignified way. I've seen people, I know 3 people in my immediate circle who died in hospice. And I felt it was a very dignified way because they were surrounded by their family members. They were surrounded by the people who loved them. And they were in their own bedroom. And they passed, but I felt they did it in a very dignified way. And also depression. If you know you have a terminal illness and you know you have X amount of time to live, how can you not be depressed? What are you going to be in a happy state? You're going to be absolutely depressed. So depression at the end of life, the dread of all that's happening, this tragedy, these are some of the reasons why people want physician-assisted suicide, and they make that choice. They get a diagnosis from a doctor. They got 6 months to live. I'm sure they have suffered before that 6 months too. It's just like, when you get a diagnosis, they have 6 months to live. Sometimes people know about they having a chronic illness that's getting worse and worse and worse. And now it's actually come to a point where they got less than 6 months to live. So there are various reasons why people do physician-assisted suicide, and it's an individual choice. I wanted to talk about suffering versus pain. When someone's at the end of their life and they have a illness that is going to succumb their existence, many of them suffer. Also, many of them in pain. Death can sometimes be very painful depending on the diagnosis. When you think of pain, think of some kind of physical pain. It could be psychological pain. It could also be spiritual pain. So pain is something that you could actually put a gauge on. When you think of suffering, suffering is more perceived than actually a physical pain. Suffering is when you feel loss of control. You feel that your family members are suffering because they know that you're dying. Another big concern about suffering is if you have a pain and you don't know what it is, you just suffer because you really can't identify exactly what the pain is. But suppose the physician tells you, oh, that pain is caused by ABC, then you could sort of acknowledge exactly where the pain comes from and you feel better and actually you suffer less. When you understand what the pain is, when you understand what the outcome is, and you understand all these other variables, your suffering decreases. So suffering is different than pain. Pain is physical, where suffering is perceived stress that goes along with the pain, and it could be coming from many different sources. There's a medical ethics term called the principle of double effect, and you may be asking exactly what is this? Many patients have dealt with the principle of double effect, and this is how it works. Suppose someone comes in with gangrene on their toe and their foot into the emergency room, and the doctor says to the patient, there's nothing I can do for your foot. I need to amputate. And the patient flips out and says, no way you're freaking cutting off my foot. So the doctor says, if you don't cut off your foot, you're going to die. And then the patient says, I had this foot my whole life. Give me some antibiotics. Do something. I don't want to get it amputated. So the doctor realizes that this patient's not making good judgment, and they ask anesthesia to come down and sedate them and then intubate them, and they bring them up to the operating room. So they did this, they bring the patient up to the operating room, they amputated the foot, he's brought to the ICU. 2 days later, the fever's gone, the infection's gone, and he's fine. So all he needs is a prosthesis. Uh, the act here, the reason for the principle of double effect is that the patient was harmed. That patient did not want their foot cut off, and the doctor went against them for their betterment. So the principle of double effect is if you do something that can harm the patient, but actually your intention is good. So number one, the act itself is good. Number two, the intention is good for the good effect. Number three, the good outweighs the bad, and the good effect is not caused by the bad effect, like like a side effect. So this principle of doing harm to the patient is called the principle of double effect, and it works in different variables, and I'm going to tell you about that on the next slide. Here's another example of what the double effect is. Suppose someone has end-stage lung cancer and they're diagnosed that they have 6 months to live. They suffer from shortness of breath, chest discomfort, and extreme anxiety. So what you may do is that you may administer IV morphine, and you might do such a big dose that it could potentially kill the patient, suppress their respiratory cycle. But if they give the proper amount of dose, they actually can make the breathing easier, decrease the pain, decrease anxiety, and it may hasten death by the fact that the morphine may suppress their respiratory cycle, but they actually suffer less. So this is another example how the double effect works, especially with end-of-life care. So I ask you, you all have been in the ICU, you all have seen death, and you all have seen suffering. You've seen families fight with each other about discontinuing life support, and you've seen all these different dramas going on in life. So my question to you, do you think if a person has the right to end their life if they have an incurable disease? What do you think? Everyone has their own opinion. I can't relate to this because I don't have a terminal illness and suffering and pain, but maybe if I did, I might have a whole different attitude. So everyone has their own thoughts. I would think that most of us who have seen death and suffering and feel that a patient there's no way that they can recover and they're going to absolutely die and they're in pain, we might agree this might be a way to go. We also might have some religious convictions that don't want us to go in that direction. So remember I was telling you before that Oregon was the first state to actually create the Death with Dignity Act? I wanted to tell you exactly how their program works. The state of Oregon legalized physician-assisted suicide back in 1998. They were actually the first state in the country to do it. To make it work, you need to be a resident of Oregon. You also need to be 18 years of age. You must make 2 oral and 1 written requests for end-of-life care. That means that when you do sign off for this, you need to be completely competent in your mind that you're making the right decision. So this is what you need to do. The patient must be terminally ill with a life expectancy less than 6 months. And this diagnosis that you have less than 6 months to live has to be confirmed by a second physician. So it takes both doctors to actually make this confirmation. Also, both doctors must agree that you're competent. In other words, you are not mentally ill, you're not under severe depression, you know what you're doing. And then finally, the patient is the one who self-administers the medication that could kill them. So it's not the doctor, it's the physician, it's not the doctor, it's the patient who makes this choice, and they actually deliver the medication themselves. So this is how Oregon works, and a lot of different states sort of copycatted exactly how this was done. They actually made some improvements. I wanted to make you realize that the Death with Dignity Act was put together in 1998, and now palliative care has become a common practice in most hospitals. So they did a study and they looked at a whole host of patients who wanted to get physician-assisted suicide. And of that, about 30% of the patients who started the process died before it was completed. So almost 1/3 of the patients who wanted physician-assisted suicide died before it happened. Also, 19 patients in this period who were given access to lethal medication decided not to use it. So in other words, they went to the doctor, they got diagnosed with a terminal illness, they went to the second physician, they did everything they needed to do, they were given the script to get the lethal medication, and they chose not to take it. 45% of the patients who were given good palliative care changed their mind. I think this is a very important factor. So physician-assisted suicide at one time was your best vehicle to end your suffering. Now we have really good palliative care. If you have a really good palliative care program at your hospital, the likelihood that you want physician-assisted suicide is greatly reduced. And the good news is that we are getting much better at it. I explained before to you what euthanasia is. And to refresh you, euthanasia is when a physician will administer a lethal dose of medication with or without your permission. Many countries believe in euthanasia. So the question is it a good and painless death when the life in someone's body is squeezed from them due to a lethal drug? Is it good to do euthanasia? Do we have the right to actually do euthanasia on a patient? And some countries believe it. Not in this country. We do not believe in euthanasia. So I want to give a little bit more details about this. Let's get on the conversation about euthanasia. The difference between euthanasia and physician-assisted suicide is that in euthanasia, the physician can actually give you the lethal dose. And there are two types of euthanasia. There's what they call voluntary, which means you have the patient's permission to do it. And then there is involuntary, when the system or society decides to end your life. When you think of euthanasia, you could think of someone who has a terminal illness, then slipped into a coma, and they have no family members, so the physician or the ethics board can make a decision to end the life of that person because they feel they're not responsive, they're in an ICU, they have no family around. That's called euthanasia. In the United States and in many other countries in the world, euthanasia is definitely controversial, and in this country it's unconstitutional. We feel it's immoral and it could harm society. That is our position on it. I don't know what your position on it is. I have my own opinion, which I'm not going to share, but euthanasia is a practice that is carried out in many countries. When you think about it, someone who is terminally ill, they're non-responsive, they're intubated on a ventilator, and if they were taken off the ventilator, they would die. They're tube fed, they have hydration, and they could be kept in this vegetative state for years. How much does this cost to society? How much drain does this cause emotionally on patients and families? So you really have to think about it. Sometimes I'm not saying it's a good choice, but there are times when I see people in vegetative states and I see families fighting and no one can make a good decision. Thank God for palliative care. Palliative care and good communication with family members has made this a lot easier. When you think about euthanasia, you have to remember that physician-assisted suicide must be initiated by the person who wants to end their life. So they self-administer medications, but in euthanasia, you need to have the physician do it. Like I told you before, there are two types, voluntary and involuntary. People who do voluntary euthanasia, and they can't do it in this country, and if you really want to think about it, euthanasia and voluntary euthanasia in this country might be under the title of called palliative care or end-of-life care. So they don't call it euthanasia, but the outcome is the exact same thing. Let's dig deeper into euthanasia. There are 4 different types of euthanasia. and I'll explain what each one is. There's active, passive, voluntary, and involuntary. And many countries follow these four models. So let's go on to the next few slides and we'll talk more about it. When you think of active euthanasia, that means that the doctor will actually inject a lethal medication into you that will end your life. And when you think of active euthanasia, think almost like physician-assisted suicide, where the patient makes a cognitive, well-balanced decision to end their life and the doctor assists them. So the difference is with physician-assisted suicide, the patient takes the medication that would kill them. But with active euthanasia, even though the patient is cognitively aware of what they're doing, they have the doctor give the medication that will kill them. So this is what is called active euthanasia. There's another term called passive euthanasia. And what that means is that you refrain or you stop life-sustaining medical treatment in order to let the terminal patient die. So you have someone who is terminally ill, who has less than a certain amount of time to live, and they're really, you pull the plug. So basically, this is what you would call a terminal wean from a ventilator, or this is where they might load up some big boluses of morphine and stop their respiratory cycle. So passive euthanasia is that you refrain from life support equipment such as a ventilator, tube feeding, and so on. And this is what they call passive euthanasia. To finish up our talk on euthanasia, there are two types. One is called voluntary and the other one is involuntary. When you think of voluntary euthanasia, it's the same thing as active euthanasia, that the patient is awake and cognitively making a decision to have the physician end their life. So that is called voluntary euthanasia. Where involuntary euthanasia, which is actually used in many countries, I got a couple of slides a little bit later, I'm going to talk about that. This is when the patient who is in a persistent vegetative state and they are not aware what's going on, such as a brain death or a coma, and then the physicians decide to end their life by giving them a lethal dose of medication. Involuntary euthanasia, you may say this is cruel, but how many people should be in a persistent vegetative state in a bed, on a ventilator, not responsive for years and years and years? How much does that cost society? Is it like we should just have an endless ventilator running forever, constantly tube feed them? I don't know. Everyone has their own choices about this. So we're also going to talk a little bit about a living will or an advance directive, which might sort of prevent this kind of thing from happening. This is going to come a little bit later. So where is euthanasia legal in the world? In the United States, euthanasia is not legal, but in recent times, palliative care has almost looked like euthanasia, because how many patients are actually have a terminal wean? How many patients are actually get huge boluses of morphine? So people are assisted in their end of life, which is actually the same as euthanasia. But in other countries, it's made by the physician's choice, not the patient's choice. And in human euthanasia is legal in the Netherlands, Belgium, Colombia, Luxembourg, and Canada, but it's illegal in the United States. So when you think about this, there are countries in the world the physicians will make a choice whether to end your life. I'm sure it comes to an ethics committee. It's not just one physician's choice to end your life. But if you're terminally ill and you're in suffering, or if you're in a vegetative state due to a car accident, they don't leave it up to the family's choice to keep them on a ventilator forever. They got a budget and they sort of keep to their budget. So if someone they feel is no likelihood of coming back, they're going to end their life. And even Canada, Canada is like, a modern country. They're right next to us. They practice human euthanasia too. So it's kind of interesting. So as healthcare workers, I ask you, of everyone hearing this presentation now, how many of you have an advance directive or a living will? And I've done this with live audiences, and many times it's surprising that such a small number of us have an advance directive or a living will. Some people have it, most people don't. Really, predominantly, most people don't. We have all seen suffering. We all have seen death. We all have seen family members, fighting with each other about continue life support or end life support. So, and we all know what we want. I mean, I know exactly what I want. I want, if I ever had a code, I want to be resuscitated. And if I had a code again, I want to be resuscitated. And if I had a code again, I want to have it be resuscitated. How long do I want to stay on mechanical ventilation in a vegetative state? I know, 30 days. If I don't come out of it in 30 days of being in a vegetative state, I want to come off the ventilator. So the idea of having an advance directive could almost dictate exactly what you want. An advance directive is much more powerful than a living will, because an advance directive can have a proxy. A proxy is someone who could speak for your behalf if you can't speak. So if you got into a motor vehicle accident, you had some kind of brain trauma, and you really can't speak for yourself, maybe your proxy or your surrogate or someone who could speak for you, your power of attorney, can speak for your beliefs. Sometimes beliefs are better. A friend of yours can know more about you than your spouse or your brother or your sister. Sometimes people who do advance directives and they make their proxy a close friend who knows their intimate feelings about everything. A living will is almost the same, but it's a little bit more watered down. How much does an advance directive cost? Dirt cheap. You can get the template online. I know there's problems with advance directives and living wills in the emergency room with intubation, do not resuscitate. I know there's problems. I can't understand why, with all these new modern computer systems, that an advance directive is not actually uploaded somewhere on a central database, just like your driver's license. But these two documents can be very, very important, especially at the end of life, especially about the care you receive at the end of life, especially if you can't make that decision yourself. So just a reminder, with an advance directive, you actually can write down what you want when you can't make decisions for yourself. And God forbid it happens, there are times when you can't really make decisions for yourself. And you also, when you do an advance directive, you need to be competent. You really can't be, under duress, or you cannot be depressed. You really got to sort of know exactly what you want, and you have to know the ramifications and the consequences of your choices. In summary, I want to thank you for joining this presentation. I know that end-of-life care, palliative care, physician-assisted suicide, euthanasia are all hard decisions. You really need to know the rules for each state, because each state has their own particular rules about physician-assisted suicide. You also might want to consider your religious beliefs. Like I told you before, I feel that, when we're not in pain and we're not suffering and we're not have a terminal illness, we might be very strict in belief, what we believe, like me, like I told you before, I'm a Roman Catholic. I feel like physician-assisted suicide will about burn in hell. I am, I have my faith. But, maybe if I was suffering, I might have a whole different opinion. So you really got to consider your religious beliefs when you make decisions like this. And I want to thank you very much for joining me. I got some great references on the next slide, and I'll share that with you now. So these are my references. If you wanted to learn more about physician-assisted suicide, or if you wanted to learn more about euthanasia, this is a good place to start. I want to thank you all for joining me, and hope to see you next time.